So after the presentations by Sean and Elmer, so I hope I can leave this session as a free and happy woman. But we have to see, because I'm going to present on a cluster randomized controlled trial in 9 different countries. But first of all, I would like to thank sincerely Professor Francis Sheely for inviting me to present here today, but also to congratulate her and the organizing committee on this amazing, it's first of all an amazing conference when you look at the range of topics and the expertise and the international collaborations, but also the very high quality. So it's really motivating to see this here. So I've been asked to obviously to focus particularly in my presentation on the rationale for such a large-scale cluster randomized controlled trial, pragmatic trial, but also on learning experiences. And when I was listening to Sean and Elmer, I was thinking what's standing out to me after a 4-year trial. And believe it or not, I'll say our kickoff meeting was January 2020, and everybody knows what happened in March 2020. And our approach for the intervention was a blended intervention. So you can read my mind here, but I will clarify a bit more. But the bottom line, and I hear it through Sean and I hear it through Elmer, which is it's really impressive to see your leadership and amazing that none of you are in jail. No. Yes. But amazing is the persistence, and I think this is where we can meet each other, because to transform a blended intervention project within a couple of months across 9 intervention countries during the COVID pandemic has required persistence, not only from myself, but from all the 9 intervention countries. And in addition, so in total, 15 partners in this collaboration, including Australia. And we met all those differences in different regulations. And if you work across global consortia, sometimes with public health emergencies, something happens in one end of the globe and there's restrictions which have not yet happened in Europe or here in Ireland. So a lot of learnings, but a very rich endeavor. And coincidence or not, when I was just checking a few emails there, one of our collaborators said, and when is the main outcome paper going to be submitted? And this will be tomorrow. So everything is happening at the same time. So we were successful here in the Horizon 2020 call, very competitive, as everybody knows. And I'm not a person who walks around with disseminating all the positive news, but it's still quite remarkable with I have done a lot of trials over the past decades, but I've done so many other studies as well. So it's not that niche area for ourselves, but I'm pleased to say that out of 141 applications, the MENTUPP application was ranked first in the H 2020 competition. So, and I think certainly some of the scenario B and C's, where we thought we would never need to resort to, we had to put that in place when the COVID pandemic started in March 2020. So overall, 18 multidisciplinary partners across 11 European countries. And we also had a partner in Australia and the US. I think probably today, unfortunately couldn't be here in the morning, but I've seen titles where I think, yes, multidisciplinary collaboration is very important, certainly in pragmatic trials. So we had a lot of expertise, public health, occupational health, psychiatry, psychology, biostatistics, and also the aspect of lived and living experience. So we really built an important group, despite in March 2020, for 2 years, we had to transform everything online. We couldn't see each other, couldn't meet, and we had to adopt our intervention. When you have a rich consortium, obviously that's already half of, the game and achievements. However, don't forget about important advisors. And usually when I look at advisors, I look at people with global expertise, hoping that they have managed and survived certain emergencies. And that was certainly the case for some people here. Sometimes you also have to work with criticism, and not so surprisingly, but some of our advisors ahead of the implementation said, we think this trial is too ambitious. So when you're leading a group and then you think, oh, it's not going to happen. And, so fortunately we made it with a lot of the adjustments, but also with the excellent input from our advisors. So when you're thinking about conducting a trial in mental health in the workplace, you cannot just in an ad hoc way choose your workplaces. We put a lot of effort in the justification. Some of you may be surprised to see healthcare here, but in the area I work, mental health promotion, suicide prevention, some of you may be surprised, but across healthcare workers globally, it's one of the groups where suicide rates are highest, particularly amongst nursing staff, GPs, and doctors in general, and also levels of burnout and absenteeism. So that was one of our justification. In the area of ICT, high levels of mental health conditions and high levels of absenteeism. And in the area of construction, equally high levels of absenteeism, suicide risk, and mental health conditions. So that really constituted an important rationale, but very different sectors. So therefore, also you have to have the different expertise on board. So we had a number of important levels in total. We had 10 different work packages. But first of all, before building what we call the MENTUPP hub, I'll say a little bit more about that later, which originally was aimed to be blended, but we transformed everything online, including interactive skills training and exercises, because we didn't have a choice. And then we had a 6-month pilot study, which was obviously highly recommended in an area where we really couldn't resort to other examples of large-scale cluster randomized controlled trials. And then following the pilot study, work with the learnings and improve both the intervention and the trial design for the cluster randomized controlled trial. One other stipulation, but this was part of the funding call, is we were asked to focus only on small and medium enterprises. Now, obviously, that constitutes a huge representation of the workplace sectors across the globe. But overall, SMEs were already associated with overall high levels of absenteeism, also high levels of mental health conditions, prior to COVID, because during COVID, with those rapid studies and rapid reviews, depression came a bit to the background. Anxiety was one of the has had increased in prevalence quite quickly. So we took that on board as well in our intervention. I'm working in the area of mental health and suicide prevention a long time, and something that started to become a frustration is that it was difficult to get buy-in and support for what I felt was urgently needed is a more upstream approach to mental health promotion and suicide prevention, because we have many resources whereby we say, following an act of self-harm, following suicidal ideation, there are many evidence-based interventions now, but how can we prevent the first act of self-harm? How can we prevent deterioration of mental health conditions? So I was absolutely delighted with the successful grant that finally we have an opportunity to focus on let's say, the overall population in these sectors without necessarily retrospectively only looking at those who have reported mental health conditions. So I think in that regard, it's an encouraging example. I already highlighted the rationales to select the different sectors. And again, one of the important learning experiences across the 9 intervention countries. And for example, we had countries on board like Kosovo and Albania, then Western European countries. But in the construction sector, in some of these countries, the door was closed. So the level of stigma was so high that managers indicated, we don't want to have anything to do with you, or we got these responses as, finally, we have everything under control, and here you're coming to upset the situation with something where you talk about mental health and suicide prevention. So that it was important for all these reasons to have a pilot study, because we needed to optimize our recruitment approaches and also our communication. I hope that Sean and Elmer also agree with me that at this stage of where we are, whether it's health or mental health interventions, a single level intervention will not make a significant difference, or will not change the world. So we really felt, even though it was extremely challenging to be only online in these first 2 years, but we developed what we called a multi-level online hub, MENTUPP hub, whereby we very specifically focused on resources, interactive resources to deal with stress, burnout, and what I call the mild to moderate mental health conditions. And then we had specific resources to focus on the more severe mental health conditions. And we learned that reducing stigma, improving communication about mental health had to be a cross-cutting resource throughout all the MENTUPP hub. We call it modules and sessions. Yeah, so years ago, we all went for the single level intervention. I really would say to people, take a step back and look at how you can build a multi-level intervention. So here we did have resources addressing also the organizational atmosphere or the organizational setting of a workplace setting, groups. We have resources for leaders, the supervisors, the health and safety officers, and then obviously also the individual employees. These are just a few examples of the range of modules and sessions that became part of the MENTUPP hub. And we knew it, but we learned even more during our pilot study that the whole presentation of information, interactive modules for construction and health and ICT, they had to be very much tailored to the right communication, the right imagery. And for example, in hindsight, one of the very effective, or based on our qualitative feedback, the effective resources were so-called peer support videos, whereby not actors, but real people in construction provided testimonials as to why interacting with such a hub would be beneficial. If I have time, I can quickly do the video of the MENTUPP hub, but obviously there's information to our website as well. We are, as I said, it has taken a long time to move towards our main outcomes paper, which will be submitted tomorrow to a very major journal. So we have to hold off until we have that before we can release the MENTUPP hub more freely. Oh, sorry. Yeah. When you see this design, you would, taking a step back, you would say some of our advisors said, this is too ambitious. How can we ever put this in place? But we did. Obviously, it was great teamwork. So across the 9 intervention countries, we recruited in total 62 SMEs divided, stratified by control and interventions within construction sector, within health care sector, and within ICT. And we had a 6-month follow-up following the baseline and a 9-month follow-up. And I'm really very pleased to say out of the 62 SMEs, 61 stayed with us until the very end. Now, I have to admit, obviously, within these SMEs, there was variability in terms of uptake, engagement with the MENTUPP hub, and there were issues with attrition within these SMEs, but I think across the different cultural settings, this is certainly, I think, partly a good news story. Then, and I still think back of when we finally could get out of our boxes after COVID. So we had a very engaging. I said we immediately do a meeting. It was coincidentally in Albania, and I said we do writing days. So we wrote our drafts for our papers, and then we only had initial outcomes, but there are some really encouraging outcomes. So comparing the SMEs, where employees and other staff accessed the MENTUPP hub versus those who didn't over the 9 months. In the intervention, SMEs, we see overall statistically significant improvements for reduced anxiety, reduced depression and burnout and stigma, and overall increased mental well-being. There was, haven't really spelled it out here, but there were let's say, some conflicting findings across the different countries in terms of perceived psychosocial stressors in the workplace. But then if we look, for example, at the baseline outcomes for construction, so the level of awareness of mental health in the construction was very low. So via the MENTUPP intervention, people finally became aware of what may not be appropriate in the workplace, what may induce mental health issues or conditions. So when you find adverse findings, don't immediately say, this is an ugly trial, but look at it in terms of what do these participants, what have they learned possibly that may constitute unexpected findings or findings that may not be so straightforward. It goes without saying that we learned a lot about barriers and facilitating factors in how to implement such a trial in 9 intervention countries. And one thing I don't want to think too much about, but I think it was at least overall 12 months, every Thursday morning, 1 hour with the team to work with the research officers every week to pick up on any immediate issues or deviations whilst they were conducting the trials. So again, persistence is obviously key. And without persistence, it's much harder to stand over your standardization. So that is obviously completely linked. Strangely enough, even though we as a team had issues obviously in transforming the hub from blended to online, the COVID times eventually worked to our advantage in terms of a greater understanding of the needs and the importance of a resource like this, certainly in the health sector where supervision was not happening maybe for 6 months because staff had been diverted, and equally complex issues in the construction sector, COVID-related issues, but also the economic drawbacks. So for people who are interested, there's a range of outcome papers already and also some of the systematic reviews. We had with our colleagues in Scotland, we had a particular lot of emphasis on trying to be as prepared as possible in terms of the global barriers and facilitators for such a cluster randomized controlled trial. And we have updated this in some of the systematic reviews as well. So overall, obviously, many learnings, and so we I know I have very limited time now, but one I think achievement and I think a good news aspect is with such a major application, even if you think blended so far had the best evidence overall, so online and face-to-face, but we didn't have a choice, and ultimately we were able to almost simulate some of the in-person interventions to online in this hub. The support from stakeholder engagement is critical, so we had already our advisory group, but each of the 9 countries had a steering group with representatives from construction, health and ICT, but also people with lived experience. And as I said, using multi-level approach, but also multi-channel approach to knowledge exchange and dissemination. And I don't think this has contributed, but we ended formally the H 2020, the MENTUPP trial in December 20. That was December 23. And so in November 23, we were informed that, particularly based on this work and another application, we were successful with the Horizon Europe Prosper H cluster randomized control trial, so we haven't given up. And now we're moving into 11 countries. So that work is currently ongoing. But the multi-level approach definitely stood out in the positive feedback. Capacity building obviously is key within the trial and across the countries, but sometimes when you're preparing for such a large-scale trial, you're writing the grant, it may be sometimes irritating when you see the sections on how to sustain a trial that you haven't even started. But then my advice would be to look into recently published trials, and we have to keep learning obviously from each other, particularly in terms of facilitating the implementation of these trials. And in hindsight now, there were moments where I wasn't that happy, but in hindsight, I'm really happy that we had all the different countries on board, because we learned a lot about the different ways of facilitating recruitment. Also, we learned a lot about different ethics procedures and obviously data protection, and we need to know. To stay out of jail. But it was also, it gave us that very rich scope, of collaboration, but also interpretation of our outcomes. So you can see that once we got out of our boxes after 2 years, we were very happy to meet each other. So here we see us with our colleagues in Albania and colleagues in Spain. And then last but not least, when we started the trial in January 2020, most of us had not worked with each other before. So it is just encouraging to see that we tailored everything online. And we developed this online team as a team, as if we were working together in the office across all these countries. So that's something, it's hard to predict sometimes, but it's worth investing because it is linked to your work, the quality of the implementation and standardization. So thank you very much. Thank you.